Okay, good afternoon. Welcome to Medical Grand Rounds. Today we have Dr. Amanda Wieland presenting on non-alcoholic fatty liver disease. Dr. Wieland is an assistant professor in the Division of Gastroenterology and Hepatology here at the University of Colorado. She received her bachelor's degree in biology from Duke University and her MD degree from University of Texas Southwestern. She also received a master's degree in clinical sciences from the University of Colorado. Dr. Wieland did her house staff training at Washington University and then did her fellowship training both in gastroenterology and in liver transplantation here at the University of Colorado. And we were fortunate to keep her on as a faculty member. Dr. Wieland has focused her career on non-alcoholic fatty liver disease, focusing on the clinical and research aspects, in particular therapeutic approaches to this very difficult to treat disease. So welcome, Dr. Wieland. Thank you very much for presenting today.
All right. Thank you so very much. I am so honored to be allowed to talk to you guys today. And in general, I'm so grateful that there is interest in this topic because I think that's one of the key take homes today is really recognition and really excitement and advocacy for this group of patients that I'm sure all of you have seen and take care of as well. Um, so no disclosures. So the hopes for today, I'm hoping what you guys can take away. Identifying patients at high risk for non-alcoholic fatty liver disease and especially NASH, we're really going to emphasize the importance of that subtype of NASH in the spectrum of fatty liver disease. Really want to understand the non-invasive risk assessment for patients with NASH and NAFLD, and also outline these treatment strategies that really focus on a multidisciplinary approach to really target all the aspects that affect these patients. So I have a few cases for you today, and these are all patients that I've taken care of across the full spectrum of fatty liver. So I want to share those with you today. So our first case, this is a 29-year-old Hispanic female, has a BMI of 40, diabetes, hypothyroidism. So just right off the bat, just knowing only that about her, just think about what do you think her likelihood of having fatty liver and then also NASH would be. So you can think about what you think it might be. So you guys might not be surprised that just having fat in the liver up to 80% with just those risk factors, and then 40% potentially has NASH as well. So just briefly looking at the spectrum of this problem. So it is a huge issue. It is the most common cause for abnormal liver tests in the United States. The true prevalence is really unknown. There's different ways this has been looked at, but it is out there. At least probably 30% of our population, and this is both in the United States and then around the world. This is a worldwide problem. In the US, if you just look, these are old numbers, but just to give a brief idea of what spectrum we're looking at, over millions of in the general population, looking at these numbers, almost 100 million with NAFLDs, and then 1 in 5 with NAFLD could have NASH. And then again, progressing to advanced fibrosis and cirrhosis. So millions of people out there with under-recognized cirrhosis potentially. So one thing to think about, knowing there's such a big problem out there, kind of grappling with it, should we be screening? Should we be looking for this? You can see across the spectrum, universal screening has not been adopted. Both in Europe, Asia, and the American societies really haven't talked about universal screening. But where you can see really the work is going is thinking about this in these high risk populations. So just being aware of it. The several societies have talked about, focus on screening of this high risk population. The American Liver Society, the ASLD, really didn't comment on this specifically, but if you look in their guidelines, they talk about this vigilance, which really in the end is the same idea, where when you have somebody with metabolic syndrome, the more risk they have of metabolic syndrome, the higher likelihood of NAFLD and NASH, which I'll outline today. The Diabetes Association more recently actually came with a more clear recommendation where they do say that you really should be screening in this high-risk population. And they talk about that high-risk group being the diabetes, pre-diabetes, especially when you assess for even these mild elevations in liver tests. Think about it in those patients. And also those that you see this fatty liver incidentally on imaging, which our radiologists, I think, are getting better about telling us about. What screening modality? Still not known, so there's still a lot of work to be done there. Honestly, liver enzymes ultrasound have their definite limitations. There's this move towards transient elastography to try to identify fibrosis, which is really the biggest prognostic indicator for increased health risk from NASH and NAFLD. And so that's really, I think, where things are moving eventually, but access and those things are still challenging. So exactly where that will end up in the end is unclear. So just kind of get our definitions down. So non-alcoholic fatty liver disease, also NAFLD or NAFLD, some people will say as well. So you start out with a normal liver. All of us know the body is not supposed to store fat in the liver. It's become so common, we almost think that's, maybe it should be there, but it really shouldn't. That's not normal. So once you start to see fat in the liver, that's steatosis or, simple steatosis or just NAFLD. You hear different terms out there. What's really concerning is when, from a liver standpoint, is when people get NASH. And so that's going to be the steatohepatitis. Itis, as we know, inflammation. So blue on the biopsy, blue is bad. And so that's really indicating this risk for progressive liver disease is greatly increased and even risk to develop cirrhosis. So it's really the patients with NASH, which is a biopsy diagnosis, and I'll get into that as well, that can progress to cirrhosis. You can see if you do a biopsy and you just see simple steatosis without inflammation, fairly unusual for them to progress to cirrhosis from NASH, to progress to cirrhosis in general, but NASH is the one that can present around 20% over time has this risk for cirrhosis. So one thing that's really important is, I wouldn't be a liver doc if I didn't show you pictures of the liver with the microscope. So one thing I think is really important, and this has evolved with time as well, is how well our pathologists actually tell us if somebody has NASH or not NASH based on biopsy. So the three things you need to have on biopsy to say somebody has steatohepatitis. The non-alcoholic actually is the clinical part. So they should just be telling you if they have steatohepatitis. They have to have steatosis. They need to have ballooning. So this is something where you can see that cell in the middle of that slide there, which is swollen and injured. So it's actually signs of injury. And then, of course, the inflammation as well. So you need to have all three of these factors. So technically, you need to have a NAFLD activity score, which is the sum of these different measurements the pathologist gives you of around a 3 or more. So you'll see this reported different ways. This was originally developed for research purposes, but it's useful clinically because we're starting to have this data and a lot of the prognostic factors and scores look back at this and saying who seems to have a higher risk to progress. So that NAFLD activity score will come back as we're going through the talk today. The other thing that's really important is the stage. This is something else we can get by biopsy, but we're trying to find other ways to get this information because the single biggest predictor of health risk and outcomes is the stage of fibrosis. The stage goes from 0 to 4 for the degree of fibrosis in the liver. The stage 1 to 2, the way fatty liver causes fibrosis, there's both this little chicken wire of these like little tendrils that surround the sinusoids, and then you also will get periportal fibrosis. So it's usually a combination of those two that's in the stage 1 to 2. And then where we get much more concerned is when somebody hits a stage 3, and that's where they have these tendrils or bridges of fibrosis. And then, of course, the final stage where they actually have cirrhosis or well-formed nodules is where we're the most concerned. Now, I want to step back and just emphasize a really important point, and hopefully this will come through today, that fatty liver affects the whole body. And while, yes, we care about the liver, of course I do, and the NASH component, just seeing fat in the liver increases the health risk in your patient. So this study was looking at a group of patients without NAFLD. And so that's really just your baseline risk factor of cardiovascular disease in the population. And they compared that to people that had isolated steatosis without NASH and then NASH. And you can see that cardiovascular risk, or that light gray bar, doubles with just having steatosis. And then, of course, stays elevated in NASH. And then NASH is where you really see that liver-related outcomes. But if you look, there's just as much mortality from cardiovascular as liver-related disease. So it's really important to focus on both in these patients. So getting to that, this is a question I get all the time, and it is super important. Statins. What do we do with statins in these patients? So the real punchline here is that statins are safe in patients with liver disease and should be prescribed in all high-risk patients based on the current guidelines from our cardiology colleagues and the associations. So they really are important, and you shouldn't fear putting your patient on a statin. Some data even suggests that statins really improve the liver test. You'll put them on a statin, the numbers will get better. But they haven't shown robust improvement specifically for NASH and fibrosis, so they're not approved and used just to treat NASH. Caveat, it can be scary to start a drug we know can cause a mild elevation in the liver tests when they already have elevated liver tests, so I understand the concerns. It really just requires some more careful monitoring than you would do with somebody who has baseline completely normal liver tests. So I say if, especially if they're over 3 times the upper limit of normal, there's no like direct contraindication. Of course, if they're in the thousands, it's not for fatty liver. So you probably don't want to start a statin at that point. But it is really important. We're always happy to field questions in that if you just want to make sure that you're doing what's best for your patient, not causing an issue. But I just say, can start them, careful, monitor the trend. So the punchline of this is that NASH, since it is on such a rise and it can lead to significant liver disease, that it as a cause for end-stage liver disease and need for transplant as a surrogate for that was predicted by 2020 to become the leading indication. And the only thing that slowed it down was alcohol. Is also on the rise as well in this country. You can see on these graphs that the orange is hepatitis C. So we have made major strides in that. And so we've seen a decrease in indication for hep C for obvious reasons. In this trend, though, from 2004 to 2016, NASH has increased overall by 109% as an indication for transplant. It has become the leading indication in women. So for women, this is now the leading indication for liver transplantation, increasing by 91%. Overall, it's number 2. When you look at men and women, you can see that blue bar of alcohol in men has been increasing significantly. One important thing to know is there's also these subgroups that have super scary numbers where you can see that there's this been increase over 3,000% increase in NASH with the complication of HCC in Hispanic women. So women and also these different ethnic groups, there's really a major rise in this risk of NASH and progressive to liver morbidity and mortality. So getting back to a young Hispanic woman with these metabolic comorbidities. So we know she's got these risk factors. We know she's enriched in those. So what do we do next to stratify and guide her care? So the first step is really just, looking at our labs and doing these non-invasive scoring systems. And these are very easy to do, and they're pretty good at ruling out advanced fibrosis, especially cirrhosis. In these indeterminate, they don't tell you if they have NASH or not, so they don't get to that. But trying to just catch those people that are getting significant fibrosis, they can be very helpful. The FIB4 and the NAFLD fibrosis score are a couple that are non-proprietary, from basic labs you already have. I like this particular calculator, this NAFLD calculator that you can get on your phone. It's by a British guy, so that's the one thing is you got to make sure you change it to the American units or you can get very confused. But it's nice because you basically just put the numbers in and then it gives you these risk calculators. So here's the numbers for our young lady. So you can see her AST and ALT are more elevated than you might expect for, but it's definitely in the range we can see from fatty liver for sure. And that was partly what brought her to attention. But nothing major jumps out. She got normal liver synthetic function, normal platelets. Her imaging actually looked okay as well. Her spleen was normal sized. And when we plugged her numbers in here, her score came out actually in a fairly low risk group. A caveat for these scores is that age has a big impact. So it's going to always under risk stratify young people. And then it always kind of inflates on the older individuals as well. So you'll almost always get an indeterminate score in an older individual. So for her, she was scoring pretty low, so we're reassured. But one caveat is I always worry about these younger people. And we know this, her ethnicity and her degree of obesity are very concerning. So, and these, we think about doing these other measurements of liver stiffness. And so there's a couple options out there that are available in clinical care. You guys may be aware of these. They're becoming more and more available, especially the FibroScan or transient elastography. So benefits of transient elastography, it's quick and expensive, reproducible. You can follow it over time. Overall painless. And it actually gets a bigger area of liver than you would get with a standard biopsy or gold standard. And basically, there's an ultrasound probe that goes on the side, obviously where the liver is, and it taps on the side and sends a vibration through the liver. And the speed of that vibration correlates with the density or stiffness of the liver. So you get a stiffness measurement. MR elastography is something to know about as well. You can actually order this. There's a little bit of challenges with getting insurance authorization and coverage. It's used much more in research studies as well, because it's nice. You can also get some fat quantification and other measurements too, but it can also be a nice tool to have as well. In general, the qualifiers for these is that inflammation, congestion, other types of liver disease, higher liver tests may artificially elevate these. So you have to kind of always look at them as a caveat. So we did a fiber scan on this young woman, and you can see here, there are two scores that you get. The main one I want you guys to focus on is the orange. That's the KPA, the kilopascals, the E score, elastography score. And so a 17.3, it depends on the type of liver disease, but you can see there for a 17.3, that falls into concern for potentially cirrhosis. So that cutoff of 14. Remember, her liver tests were a little elevated, and when they're above 100, then we tend to worry inflammation is going to affect the score. So we could be overstaging her. But, of course, this is also something we're more worried about as well. Just so you guys know, that CAP score, that blue score, has to do with this estimate for steatosis. It's a real rough estimate. I look at it in just kind of really big categories of, is it suggesting really no steatosis, moderate, or severe? That isn't a severe score. This gets us to the question of what's the role for liver biopsy? When do we need to get these more invasive tests? So liver biopsy is still our gold standard, although some would argue it's more of a bronze standard because there's a lot of caveats for it as well. And it's really important to characterize the histological alterations in patients with NAFLD and to actually diagnose truly NASH. It's really our only way to diagnose NASH at this point, since it is that histologic diagnosis based on those parameters I outlined for you guys. However, it's expensive, requires actually having a good pathologist that gives you the right information. We have wonderful pathologists here, and they do a great job of giving us the right information. And of course, it carries morbidity. Patients also don't like doing it. So even if they say they're going to do it, sometimes they never show up. So you always have to make sure they really are engaged in the process. So really, it should be in those that'll benefit the most, obviously. And so we consider biopsy two big groups from a fatty liver standpoint. So when you do have concerns for steatohepatitis, especially with more advanced fibrosis, and you feel like really getting that true diagnosis is going to affect your medical management, either your monitoring or consideration for a clinical trial, and in a younger individual, I have a lower threshold for doing a biopsy because I worry about their risk, health risk in the future. The other big time is if there's a competing diagnosis that you're not sure, there might be something else. A lot of fatty liver patients have mildly elevated autoimmune markers or high ferritins or concern for maybe iron overload. So we'll do biopsies in those cases. So if you need to exclude other etiologies that we treat very differently, that's an important reason to do a biopsy. So she undergoes a biopsy because we were worried about this fiber scan in her wrists, and it did confirm steatohepatitis. She had a NAFLD activity score of 5 out of 8, so moderate to high degree of inflammation happening in her liver. And she also had early bridging fibrosis, which to me is super scary that you have a 28-year-old with advanced fibrosis. So definitely affects her long-term prognosis. So what does this mean for her health? We have this one time point. So what do you tell her? I really love this tool. This is a NAFLD simulator. I probably get a little too excited when I go over with the residents. It almost kind of seems like a video game to me. So this NAFLDsimulator.org, it's a wonderful tool that's been put together through a grant for the American Association for the Study of Liver Disease through a group from Mass Gen and also San Diego. You can go to their website. They've got great information on the tool. Basically, it's an open access tool that gives this mathematical modeling to simulate the natural history of NAFLD in different patient groups. And it was validated by 3 large observational trials with biopsy proven stages of fatty liver. And so you put in 2 main parameters, their age and then their gender. And then you can compare where on the different spectrum of NAFLD, what their health risk would be. So for her, they give just an output of survival. So 29-year-olds that, we have across the spectrum. So you can see there the different spectrum. NAFLD would be, biopsy that shows fat, but no NASH. and then the NASH with the different stages of fibrosis. So no fibrosis, 1, 2, 3, 4. And so you can see how that affects her mortality. So she came, we'll kind of round up to a 3 for her. So, her 10-year mortality isn't as high, but it's still very concerning to have a, 92% only survival for a 29-year-old. Well, I find this to be very helpful and kind of demonstrate some important points here is looking at where does her mortality risk come from. And for her, it's really, there's a significant amount of liver-related mortality skewed in these younger individuals. They still have the non-liver cardiovascular, and that's still super important to not forget about. But these are the ones that, we're talking about needing to do a transplant, liver cancer, all those things. So you can see that, she's progressing to an F4 in the, near future. That really increases her liver-related mortality. So what do we do? That's the daunting thing here. So we got our information, we've got our stage. So what are we going to do for this? One thing I find that just talking with patients and educating them and stressing that, this whole spectrum and what this means for their health is a really important component of that. So having that time to talk to them about this and really just what their diagnosis is. Right? We all know the cornerstone of treatment for fatty liver and metabolic syndrome in general is working to get them in that healthy weight for them. That is not easy. And there are many wonderful people working on lots of different ways to try to address the obesity epidemic in our country. If you have access to weight loss clinics, bariatric surgery, but really engaging all these multidisciplinary approaches and really engaging the patient in all these different options and working with them each time you see them about where the best way to work on their weight health is. And then also considering clinical trials in selective cases. So very briefly, weight loss, again, primary treatment, and is highly effective if you can get there. This small study with a 52-week intervention, you can see in that last column there, NASH, fibrosis, and steatosis, significant improvements when they were over 10% total weight reduction. The unfortunate thing is only 10% in this intensive lifestyle intervention got there. So it's not easy, but it does work if you can get there. One way to get there, as you guys are all aware, bariatric surgery, a really important thing to think about, especially early on in patients. It's not for everyone. It requires a very careful, good team to go through this and have well-selected screened individuals. There are general recommendations out there for fatty liver, as you can see outlined, for metabolic issues, as you can see there. But it's really unclear if we should do it just for fatty liver and NASH. But most of these patients actually meet a lot of those other general recommendations, so it's important to consider. We still don't know for sure if bariatric surgery is going to be a fix-all, and I think the answer is it probably isn't in a fair amount of cases. This is a really interesting abstract that we had that came out in 2019 at the liver meeting. Hopefully we get a full paper as they follow patients for longer. This was a small group, 35 patients with stage 3 and 4 fibrosis at the time of their bariatric surgery. So you can see there, and then they did follow-up biopsies about 6 years plus or minus after the bariatric surgery. And the punchline is that 46% still had persistence of severe fibrosis. So there really is a lot of improvement. I mean, it's amazing that people are going down to, potentially F0, 28%, F1, 23. So there's some people that reverse significantly, but then there's this group that has persistence, and teasing out why that is something that we're still really trying to understand, why some people can regress and some don't. So it's not the fix-all, we need something better. This is where I think pharmacological treatments are really going to have the biggest role for fatty liver and NASH. It's really targeting fibrosis. So, just bland steatosis, we know what works for that. Once you get steatohepatitis and with true fibrosis, that's where we would want to have a liver-specific medication. So there is there's no FDA-approved treatments now for NASH. There's definitely some things out there with potential benefit, and I'll touch briefly on these. Vitamin E and pioglitazone have some benefits and have selective groups you might consider those in. A couple other groups that are, approved for, other indications, diabetes medications, weight loss medications, the GLP-1s and the SGL2s can be used in selective groups. Typically those are going to be used if you have somebody that has diabetes, has another indication. If you know they have NAFLD and NASH, they are a good choice for them. So So the current summary of the vitamin E and pioglitazone, and for time I won't go into this too much, but the punchline with vitamin E is, the Pivens trial was a groundbreaking trial where they showed that it did improve the NAFLD activity score, but it didn't improve fibrosis. The big caveat is they didn't study it in diabetics, which is really the highest risk group, and it also hasn't been looked at in cirrhotics. And then there's these concerns for all-cause mortality. So overall, people really haven't jumped on the vitamin E train. Like, we need something better. Pioglitazone has some potential benefits and can be used in selected patients, but again, hasn't shown decrease in fibrosis. So again, you can consider it in selected diabetic patients. I haven't seen any GI or hepatology providers really embracing and prescribing this specifically for fatty liver. So again, we need something better. And there are a lot of exciting things on the horizon. It just takes time. I think it's amazing that they've actually managed to get a vaccine approved in the timeline they did. So I'm sure you can imagine like what process goes into a disease that is over 10, 15, 20 years. So it takes time and a lot of hard work from a lot of people. You can see so many things under investigation across the full spectrum of the pathophysiology. Several, though, haven't had promising results and so aren't really moving forward. Although I will say a caveat that a lot of these are being used as combo therapies now. If they don't work on their own, if you target fibrosis and oxidative stress and inflammation, like maybe those combos are what really helps someone regress. There are several new things that I'm going to outline briefly as well that look at these different targets and that are now in phase 3. So the main ones to mention, so one point I want to make when we're talking about the clinical trials and research that's going into NASH right now is the FDA has really come out with 2 major primary endpoints that they feel are clinically significant and that these drugs are going to have to show improvement in before they're going to approve something. So the first one is they want to see potential for fibrosis improvement. So basically, greater than 1-stage fibrosis improvement and no worsening in the NASH activity. The second one is that you resolve NASH. So you go from inflammation and ballooning and it goes away. And you don't worsen fibrosis. So those are 2 meaningful endpoints that are going to have to be met to consider approving any of these therapies and medications. You can see these are all very big trials, an average of 2,000 patients, and they've all got the snazzy names. So that really means they're up and rolling. So far, we've only gotten interim data published on obeticholic acid, so I'm going to go into that in depth, but be on the lookout for more data coming out on all these because I think they're all very exciting. So talking about obeticholic acid, so I'm focusing on this mainly because we actually have some published data from the interim analysis of the Regenerate trial. This came out in late 2019. So basically, it's a phase 3 study, double-blind, placebo-controlled, and they were looking at in NASH with fibrosis, stage 1 to 3, and having a NAFLD activity score of greater than 4, so fairly active NASH. They have to have NASH for enrollment. So looking at these enriched patients that have a risk to progress, so fibrosis and active NASH. So the 2 main endpoints, again, fibrosis improvement and NASH resolution. And they looked at when they got to 750 patients that reached their 18-month biopsy, and then they looked at if they had improvement. So the punchline is they met their one of their primary endpoints at this 18-month mark with this interim analysis, and it was improvement in fibrosis, which was super exciting because this is the first medication that really showed improvement in fibrosis. Interesting, they didn't meet the secondary endpoint, so at least with the data so far, they didn't show that enough a robust resolution of NASH. But remember, NASH is also probably fluctuates more, and a biopsy is just this one time point in this long natural history. So seeing the NASH resolve, we just don't know for sure. We're still trying to understand these things. So I think this was a really interesting punchline for this trend towards improvement in fibrosis that they were seeing. So you can see here, that bottom bar of the placebo of the green really reflects the natural history you see when you're biopsying fatty liver patients, every 18 months, is they're going to have some probably just based on selection bias of the biopsy, and then also just some of the natural history that you had about the same number improve as regress. Looking at that top arm of the obeticholic acid, though, I personally find that very promising that there's really this shift towards improving fibrosis. So fewer people had worsening, and there also was a significant number that had improvement in fibrosis. And in a small subset, they actually had 10% that actually improved their fibrosis by 2 stages in just that 18 months. So that's really an important signal with this new drug. Placebo was 5%, so that does happen again with the natural history of this as well. So the take-home points I want you guys to have for beta-cholic acid is that it was the first positive trial so far for NASH improving fibrosis. Of course, there's caveats with it. 50% of patients had itching, which itching, as you may or may not be aware, can be a major issue. Although 20% of the placebo also had significant itching, so there's a major placebo effect too. But it was usually something that was able to be managed. The other thing was that there is this worsening of the lipid profile on a beta-cholic acid, but if people got put on a statin, if they met indications, it actually went back down to baseline. So it's hard to know how that would impact, but obviously concerning in a group that has this major cardiovascular risk as well. So this was submitted to the FDA, trying to ask for expedited approval, and they. I think the company was all disappointed. I think all of us was a little bit disappointed, but appropriately, the FDA really didn't feel like we had enough data yet to approve this, which is appropriate. I think we really need to see how this plays out. And so the FDA basically recommended that it get resubmitted, continue the trial and, look a little further than just this interim analysis. But I think it's actually very exciting to have something in there and know that there's promise for all these other meds too. So then getting back to this young lady. So what are we going to do next? What should we do for this lady? So should we say, don't worry about it, no big deal. We'll just see. There's these new meds coming out, maybe 5-10 years. We'll see if you can just put you on a magic pill one day. Should we think about a clinical trial? Should we refer for an intensive weight loss program or refer to bariatric surgery? So I want you guys just kind of think about where you might go with this patient. I'll let you know there's not a right answer here. I'm not trying to trick you. I just kind of want you to think about what you might offer this patient. And it really, all of these, I kind of cheat and say it's always a case-by-case individual discussion because it is. These are important decisions to really have with the patient. For her, she was trying to get pregnant. So a clinical trial is not a good idea if you're trying to get pregnant. She really, when we first discussed this concerning finding, was still very dedicated to an intensive weight loss program, although she still hasn't, even with all that help, she's still really struggling. And so she's been also working with our bariatric surgery team and really strongly considering bariatric surgery. Team, though, is appropriately working very hard with her to make sure she meets all those important criteria so that she'll do well with bariatric surgery. All right, so moving to a different patient on the spectrum of fatty liver. So this case, I think, is really trying to illustrate kind of the more longer spectrum that we see with fatty liver. And this is a very common case, I feel, that we see. So this is a lovely gentleman who had a long-standing history of obesity, also pre-diabetes initially, although progressed to true diabetes, hypertension, hyperlipidemia, so all those metabolic risk factors. And he was noted to have mildly elevated liver tests, around 2 times the upper limit of normal in his 40s when he was in the military. Had a BMI that was around 40 at that time. He got a workup while in the military and actually got a biopsy done back in 2005. They really hadn't defined how to describe the NAFLD activity score well then, so the pathologist didn't give us a lot of information in the report we ended up getting. But he did have signs of steatohepatitis, so had inflammation, probably ballooning, but had no fibrosis on that biopsy. So that was reassuring. But with steatohepatitis, the key thing is you have to watch them because they can progress over time. So 10 years go by, leaves the military now as a civilian job and it reaches his 50s. Life gets in the way of really making progress on his weight. So his BMI stays about the same. So he re-engages with the hepatology clinic, actually gets referred and establishes with us here. Now he's out of the military. And, they look at his profile and are worried about him. So this has been, I think, 6 or 7 years ago now. So we didn't have our non-invasive testing. But they decided to proceed with a biopsy, which was very appropriate. And that biopsy showed a NAFLD activity score of 7, so actually pretty concerning. So on that higher end of the spectrum as far as inflammatory activity, and actually had developed fibrosis around a 2 to 3 since that time. So it was really enforced with him at that time, the importance of weight loss as the main treatment. He also was still drinking alcohol, which it hadn't really been discussed with him, when he didn't have any fibrosis, that he needed to stop his evening cocktail. He really didn't have any alcohol abuse history or alcohol use disorder, but he was very open to stopping alcohol now that he has advanced fibrosis and also working on his weight loss. So let's just stop and look at the survival. Let's look at the NAFLD simulator for this gentleman. So just in general, in a 50-year-old, that you get a biopsy. So again, you can see it's really that stage 3 and stage 4 that you really see this mortality risk, especially stage 4. And to me, that's super concerning that a 50-year-old, which I say is quite young still, has a 77% survival rate with an F3. So that's very concerning. Now, looking at where is this mortality risk coming from in him, it's really for him as an F3, it's still really driven by his non-liver mortality in the next 10 years. You can see, though, once he gets to that F4, there really is that, that liver mortality increases as well. So we have to start thinking about both in him, of course. So he really is dedicated, starts working with his endocrinologist, his PCP. He really is working on changing his lifestyle. And then due to some concerns on the labs, gets sent back to the hepatology clinic, was lost for a little bit of time to come back and reestablish care. He lost weight. His BMI is now down to 35. He'd stopped all alcohol. It was noted when we looked at his labs, those platelets were now down to 120. And there was now concern as imaging for splenomegaly and even some early portal hypertension with a spleen of 15. So we were definitely worried about him. So we started with an updated FibroScan for follow-up. So this FibroScan showed the KPA. You can see there's 15.4. So again, reminding you that cutoff of around 14 is where we worry about cirrhosis. And so this really fit with the clinical picture we had for him. So basically we had the conversation that it looked like he had progressed to cirrhosis despite what he'd been working on in his lifestyle interventions. So what do we do now? So we have this guy, he's tried to do the right things. He's engaged in his health. Does he need a liver transplant? Stat? Do we need to set him up for an evaluation? Do we tell him nothing? Don't worry about it. We'll find a medication, a magic pill. Would we consider a clinical trial, intensive weight loss program, or bariatric surgery? To kind of think about what you might think about in this patient. So again, there's no perfect answer here. He doesn't need a transplant evaluation right now. Although I do find that these patients benefit from starting to talk about those things, because as soon as you tell someone they have cirrhosis, they think they're gonna die right away. And they also think you're calling them an alcoholic. So it's really good to define what you're talking about when you're saying they have cirrhosis and what that means. So he doesn't need a transplant now, but it's something to start that conversation, because if he continues to progress, that's something that may need to happen in the next 10 years. Would we consider, what ended up happening to him was actually considering a clinical trial. He was very interested in that. And so he became actually a part of our obeticholic acid trial that we've have multiple patients being followed here at the university. And he's been in the Regenerate trial, which is the cirrhotic arm. And so tolerating that well, he actually just is close to reaching his 18-month. And so will be due for a follow-up biopsy. As part of the clinical trial, he got a biopsy for enrollment, which of course, since he was a candidate for the trial, confirmed cirrhosis with NASH. You could also consider intensive weight loss programs or bariatric surgery in a patient like this. The one caveat for bariatric surgery is the safety in cirrhosis is tricky. You want to make sure there's no concern for portal hypertension, and it should be done at a qualified center that has experience with that. So, and our surgeons do. So one more case to kind of round out the whole spectrum here of fatty liver. So this is a 70-year-old gentleman. I also met him through working on these high-risk patients with my endocrine colleagues. So he had all the classic risk factors, obesity with a BMI of 40, which actually was much improved for him. He actually lost a fair amount of weight. Diabetes. And so he was noted to incidentally have fatty liver on an ultrasound. His liver tests were all within normal limits. And so when I didn't put the scores in here, but when we did his risk scores, he actually came out in the intermediate to high risk for fibrosis based on his numbers, which a lot of it was driven by age and his BMI and his diabetes. But he ended up getting a FibroScan to assess for fibrosis. And so you can see here, his FibroScan ended up showing the 12.4 fits in the F3. So potentially he could have, at least by this estimate, which remember there's things that we tend to overestimate. If we get a really low score, we can be much more comfortable, but these indeterminate ones, you have to decide what's best for the patient. And this was there's actually not a slam dunk here, whether or not you should just jump to a biopsy. It's very reasonable. And so it's a discussion with the patient, is this, this affects your prognosis and health risks. It's not gonna likely affect what we're gonna do, other than we could consider a clinical trial as well. So he decided to proceed with a biopsy because he really wanted that information. And it did confirm NASH with actually a fairly low NAFLD activity score, 3 out of 8. So just barely meets the criteria for NASH. And he had a little bit of fibrosis. So, and looking at his big picture, he probably had more active NASH in the past. And given he'd actually already lost a significant amount of weight, had hopefully had some regression of things. And so was actually doing pretty well. So then let's just look briefly, like, what does this mean just in general when you're thinking about a 71-year-old who you're worried about NASH and fibrosis? So for him, you can see here, there's a fair amount of background mortality in a 71-year-old over 10 years, which is, understandable. But you can see once you really do see a big drop off in the F3 and F4s as well. What I think is interesting to look at, and again, a lot of these things are skewed by age, and this is mathematical modeling, but in general, even when I find advanced fibrosis or well-compensated cirrhosis in a 70 plus or even like 80-year-old, I counsel them, it's good that we know this and we're going to monitor you and watch you, but in general, the liver is not going to be the thing that drives their health. It's still actually that non-liver related mortality. So you want to look at the whole picture. So there's some of these cases where I'll talk with a 70-year-old who isn't interested in clinical trials, has other health things going on, and we may defer a biopsy and just follow them clinically with fibroscans and imaging and just watch for cancer and watch for any clinical decompensations because we may not want to put them through a biopsy. So it's always looking at like, what are your goals and what are you trying to do for the individual patient? So I had promised you guys hope in my title, which I will say I had put together earlier, last year when I think I was looking for hope. And I think I found some. I think there's challenges for sure, but I think there's a lot of positives in fatty liver disease and NASH. We're just, in general, we're learning a lot more about it. And both NAFLD and NASH can now be easily identified early with this vigilance and really looking at these high-risk groups. And we're understanding that a lot more. And we know that it's important. And I think that really is all of you out there, like looking at this and telling the patient about it. I feel like it's much less common that I see patients that are like, no one ever told me about this. I have no idea. We're really seeing patients that their providers are telling them and they're aware that their liver is part of their whole health and it's being watched. And we can really make a difference. Like there's this kind of plus and minus about the long, slow nature of fatty liver, where it's sometimes hard to realize we're making a difference, but all of these patients, if you catch these people early, you can really make a big difference. I didn't highlight it today, but we have a lot of people where we have success stories where, we get a non-invasive monitor, they're maybe indeterminate on their FibroScan, and then they really engage and lose the weight, and the repeat FibroScan looks a ton better. And so we can really hold off on biopsy and really focus on that. And I think we'll look at all of our data and our patients we follow to see, but it feels like we are making an impact. These new therapies on the horizon for these high-risk patients that just seem to have that really bad luck of fibrosing despite even having some success with metabolic modification, they're on the horizon, they're coming. And we do have trials here. So we have several. We were on a little bit of a pause with the pandemic, but we're really going to be up and running with several. We have several that are going to be for the various fibrosis stages. I will say, to me, it really only makes sense to be in a clinical trial if you've got fibrosis. And that's really what the studies are looking at, because it just seems crazy to put what are likely to be very expensive medications with some toxicities on somebody who's a stage 0 to 1. That's just not going to be where your benefit is. Those people need monitoring, and if they become a 3 or 4, then you would talk about having them on therapy for that. And then I want to talk a little bit about my other real big hope that I have, and is this real multidisciplinary approach and all these resources that are available and all the different people that are working together to address the bigger issue of metabolic syndrome, which is I hesitate to mention the other pandemic in this country. And there's so many great resources here, so many great people that I've worked with, and I've seen them work with patients that I've sent them and have a lot of success. I just want to give a shout out to the CU Wellness Center and all the hard docs working there. They're a great resource to refer your patients. Caveat is there are insurance issues and coverage with obesity management, which is a systemic problem that there really should be more resources invested in that. I have to talk about Dr. Shelby Sullivan, who is a wonderful resource that we stole away from WashU a few years ago and has really been a champion of our bariatric endoscopy program. She is a wonderful individual to refer patients to. You can refer through the GI division and then just highlight that you want Dr. Sullivan to assess for weight loss options. And then we also have a wonderful surgical weight loss center here that they've done great work for several patients that I've sent them as well. And then I do have to mention our fatty liver clinic. I can't get through this talk without talking about Dr. Tom Jensen, who we need to clone him because he is a beast. And I have never seen someone work so hard and be so dedicated to really trying to help these patients. He makes my job super easy when we're seeing these patients together in our clinic. So our dual fatty liver clinic, really the goal of that clinic is that if you have patients that you're worried about this risk for NASH, also these NASH and NAFLD, and they're very enriched in these issues, you can send them to us, and then we really do this full assessment together, where ideally we work on getting them a fiber scan, these other non-invasive assessments, and then we help guide if they need a biopsy, if they should go in a clinical trial, all those questions that come up. To make it easy, we try to have this referral you can put in straight through Epic. Just, there is, resources are hard. There's such a big problem that we can't see everyone quickly, but we're working on trying to expand our clinic, get more providers, and really keep tweaking that so we can be more and more helpful to really help address this problem. So, all right, so that's me on my soapbox talking about fatty liver. I'm hoping, I know there's a lot of questions and things that I didn't address, so I'm hoping we can delve into those with some more time here. So thank you guys for listening.
Yeah, Amanda, that was fantastic. And you have generated a lot of questions. So I'm going to try to move through these questions kind of quickly. Okay. I want to first focus on risk factors. So after accounting for obesity, what are the other independent or interactive risk factors associated with NASH and fibrosis and liver fibrosis?
Mm-hmm. So like the biggest things are going to be, the other big thing is going to be the diabetes. So both just insulin resistance, pre-diabetes, and then diabetes. So that added risk really increases that risk for having NASH for sure. And then additively, all the other metabolic risk factors. The other thing that hasn't been captured as well, but when you meet with these patients, that's central obesity, which, with the measurements that we'll do for metabolic syndrome, although I know most of us streamlining, it's hard to get out the tape and measure everyone's waist circumference, especially since we're doing everything virtually nowadays. But yeah, that central obesity, the diabetes, the other metabolic risks, and then ethnicity really does come into play. And there are some alleles and genetic risk factors that there's the PNPLA3 allele. There's several other alleles. Those really haven't been flushed out enough to be used in clinical practice, but we're hoping, all that work and doing, G9, the GWAS type studies and things that will have better genetic data. Because to me, really, that big group that goes unidentified are those rapid fibrosers, those young people. I mean, this is seen in pediatrics. So identifying those that we can act on early is a really undermet need.
Great. Your answer touched on a few other questions. So tell us a little bit more about ethnicity, obesity, distribution of fat, and risk for NASH.
Yeah, we talk a lot about, and Tom is great about discussing this issue of lipodystrophy with patients. And I think we all know it when we see it. It's that central weight and that more toxic weight, where they'll have actually pretty thin legs, and they have less of that fat there, and they have that visceral fat. And so that's something that definitely plays a role in this. Again, the pathogenesis and a lot of that still needs to be flushed out, but we know that's a risk factor. The ethnicity component of it, it's very interesting there. We know there's this enriched population in the Hispanic, Native American too, and Asian. So that really has this high risk group. The middle risk is going to be your Caucasian. And then African Americans, at least from a fatty liver standpoint, for equal metabolic risk, diabetes and those issues and obesity, have a lower risk for fatty liver. They seem to have other metabolic complications. So although I definitely have African American patients that have NASH and fibrosis as well.
So you've just raised a really interesting question about migration and risk. So how does migration affect risk, and how does diet in native countries like Japan versus Japanese Americans here in the US affect risk?
I will tell you anecdotally, we take care of a fair number of immigrant populations. And I will say that I have a young Filipino gentleman, and then I had another gentleman, I forget which Asian subgroup he was from, that come over to the United States, switch to more of the Western diet. And honestly, the physical activity level seems to really affect them too. So I think it's just this, they're more sedentary here in the United States, and they have this lower physical activity, and they have this different change in diet. And I've seen where they gain central weight, and they have this rise in their liver tests and worsening of NAFLD. So there's definitely this interplay between the genetic risk and that environment. And basically the Western environment seems to be very enriched in risk for NAFLD and NASH. And actually the Asian population they actually have lower BMI cutoffs for the different obesity ranges. And they definitely have this higher risk for the diabetes and those other metabolic issues. Definitely a major issue in Asia, India, all those areas where this is a big problem as well.
So you mentioned that this occurs in children. And I would imagine that investigators have looked at the rate of adiposity or the rate of BMI change in relation to the risk of disease. Do you know anything about how who's especially at risk given a weight change over a period of time?
I love how your mind works. I can tell how you're such a great investigator. I will say my specific knowledge of any clear data on that, I don't know of any. I'd probably have to work more with my pediatric colleagues because I'm not sure specifically if there's major red flags for them in the pediatric population. So I'm not sure if they have. I think it is in general those that have had the longer obesity challenges since they were fairly young. In the patients I follow that are early adulthood, you hear a lot of stories, especially with women, of adolescence being a time where they put on the weight. So I don't know of any good data. So it's more kind of anecdotal and things that I've seen, but I think the ones that actually have obesity very early on, it's probably something that they struggled with the metabolic issues early on as well. And then there's that group that more adolescence hits, and there's maybe more of a hormonal component where they put on the weight. But I've seen those still be delayed a little more into adulthood as far as actually the manifestations.
And I would imagine with children, you see the opposite end where taking off weight may occur kind of quickly, and you could understand the resolution pattern.
Yeah. No, I would think that the pediatric NAFLD is interesting. Actually, from a histology standpoint, it looks a little different. They have more of that, chicken wire pattern. So there's work where they, almost kind of consider some of those pediatric ones, which might get more into this more rapid fibrosing subgroup. So you almost wonder if there is some more specific allele or risk factor that can be teased out of that group. Because, the more classic one that all of us see is that individual that it's been this very smoldering, and they get to age 70 and they have potentially advanced fibrosis, but that's not going to be their big health risk. It's these people that, are getting fatty liver and advanced fibrosis in their 20s, or even the pediatric population. So maybe one day we'll actually be able to separate those out as we understand more of the genetics and the true, pathophysiology behind what these different subgroups, what their risk is.
Mm-hmm. So mostly you're talking to the non-hepatologist. And so for the non-hepatologist, who are the patients you'd like us to screen with LFTs? What's the threshold for BMI? And then how often do you want us to screen those individuals?
Yeah, it's super tricky, and I've tried to look, none of the societies want to give a nice algorithm for any of us, because I think in the reality of the world, it always gets muddled. And as I said, the American, Liver Society basically said, be vigilant, which is interesting thing to tell people, be vigilant. I think doing, what's tricky is that, if you actually look for any elevation liver tests, what's normal liver test is a whole conversation on itself, because I feel like the upper limit of normal keeps creeping up on the lab, or truly for, women, it should be, less than 20, men less than 30 potentially. So it depends on the different groups you look at. So I have a hard time giving a hard and fast number. If somebody is having, persistent elevations that are, above, especially the upper limits of normal we use, I think that warrants further investigation. And then doing this risk profile with those, the NAFL fibrosis score and the FIB4 are very helpful to catch, especially those people that you might not realize. There's that forest for the trees, like you're looking at it kind of gradually, but if you just stop and say, this person's platelets are getting low. So I think those are things that are pretty quick and easy to do on anybody that you notice has metabolic risk factors and has this mild elevation in liver tests. What's tricky is that we don't have good guidance for that right now. And some would argue just fibroscan everybody, like just put it in the mall. But again, you have to get to this issue of like resource utilization and like with the scope of the problem, how is that going to really help? I think if in general patients are being counseled on the general risk with metabolic and obesity, that you're at a minimum doing them the positive service and just keeping it on the radar to kind of intermittently look at those labs and do those screenings. So I don't know if I gave you a very clear answer that I kind of gave it roundabout.
I think you gave us a sense of who to screen. I mean, individuals that are at that break point. So you can pass on these two questions if you want.
Okay.
So what's the relationship between inflammation and fibrosis in the liver? And if you eliminated inflammation, could fat in and of itself cause fibrosis?
The relationship, we think that you need to have inflammation to lead to fibrosis. And that's based on, as best we can understand the natural history, that bland steatosis doesn't seem to lead to fibrosis. So, there's different ways this is being looked at, but, there's felt to be this two-hit hypothesis that keeps evolving, but it's thought there's something that leads to the insulin resistance in the fat. And then this subgroup, something triggers the inflammation. What's not clear is why some people have this toxic fat that leads to that inflammation. And so those are the people that end up with the fibrosis. We don't think just the steatosis itself leads to fibrosis.
Mm-hmm. Okay. So let's talk about weight loss a little bit. What's the utility? What's the place of medications used for weight loss in this disease?
I think there's a lot of utility. I think in my impression, well, I guess number one is I feel like from a public health standpoint, there should be more resources and support and coverage for our hardworking obesity medicine docs and our primary care docs that work so hard on this major issue. My impression is that there's almost like this fear of medications to help with weight loss management because of, prior complications and issues from, poor press. But newer data and newer studies have shown they can be used and be safe and effective. What's tricky in my mind with the weight loss medications that are out there is that, one, they're not covered well. You can't get them for your patients. And there's this question of how long are they going to be on them? Is this a lifelong thing? Is the thing you start and stop? I worked a lot with Dr. Dave Saxton, who I'm over at the VA as well. So if you want to talk about an area enriched in fatty liver, shout out to my colleague, Ashley Lane, who's over there too. We're trying to get a fatty liver clinic up and running over there at a national level. That's a big push for that. But Dave Saxton works over at the VA, and it's actually a great model where they, I don't know if you guys know much about the resources in the VA, but I think they actually have a much better system to deal with obesity, where they have, a set move program where they really engage in the wellness and the exercise, and they have a lot of success. And then they actually screen patients for candidates if they're doing well with the move to see if they'd be a candidate for these weight loss medications. And, Dr. Saxton has had a lot of success with different case reports, and he gives some great talks and things about his using that. So he's really sold me that in well-selected patients, they can be a very helpful adjunct.
Good. Uh, we're going to turn to, I think this really needs to be the last question, unfortunately. There are a number of other questions that folks have, but I want to turn to the recommendations that you have for dietary intervention.
Oh, yeah.
So there's a question here about plant-based diet, and there's also a question related to how do you approach sort of um, different ethnic populations in terms of dietary changes that are relevant to what they are used to eating, and how do you accommodate that in your dietary recommendations?
Yeah, that's a really good question. Diet and culture are complicated. I start out with talking about, you know, the concept of working towards just calorie restriction. So, and really that, we don't know 100% what diet is right. And as soon as we think we know, we change our mind. And there's still so much work going into that. So that's constantly evolving. But what is the best diet for a given individual is one where they're able to lower the total calories and have successful weight loss, and also something that is not a fad diet, something that small changes they can stick with. So I really talk about that as a general concept. And then the one diet that has the most robust data, if somebody's looking for more specific suggestions, is the Mediterranean diet. That independent, when it's compared to other diets out there, for a given amount of weight loss, seems to have some anti-inflammatory properties that actually help NASH even further. And so, I talk really basically about that diet and really, avoiding simple carbohydrates, trying to increase lean proteins, whether those are plant-based, but it is good to get protein. So fish, chicken, plant-based proteins all seem to be good. Fresh fruits and vegetables, and whole grains. When they are getting carbohydrates, trying to have them be, healthy ones. And I use the Harvard Healthy Plate to kind of give them a visual. That's a nice resource out there as well. So those are some of the basic things I tell them. It is important to be culturally sensitive to what someone has access to, also economically sensitive, what they can actually afford. Unfortunately, food that's high in sugar and carbs is cheaper a lot of times. And so, really working with the individual on what their options are. It's hard too, because if you're coming from, an Asian culture or Hispanic culture, there may be a lot of carbs that are a big part of it, including white rice, tortillas. I'm from Texas. I love a good tortilla with lard in it. So I always feel a little guilty when I'm counseling on diet because I don't always practice what I preach. But I try to really have this concept with them. And again, it's so person to person, but I try to give advice and empathize about those issues and just say, really trying to just have every day be, try to make better choices. You're going to have cheat days and things, but one thing I'll outline is this idea of that it's easy to overindulge by 1,000 calories and really set yourself back. And it's hard to restrict even by 100. But if you can do that consistently and really get yourself in that negative balance, that they can get there. So it's just hard because I really do feel that these people that struggle with metabolic syndrome, obesity, they're at a disadvantage from a metabolic standpoint. And it's just, there are signals and pathways that definitely make it harder for them to lose weight. And so I think really empathizing with them, and I think a lot of these people that have struggled with weight loss have heard it before and they've been discouraged. They've not met those goals, and just empathizing with them, that's part of the disease process. And you're there to support them. And then I outline all of these amazing resources that we have here that, I'm kind of just one person in this whole team that can work with them to really figure out what works for them. A lot of people are taking care of other people and not themselves, and really talking about making their health a priority, and that they can get there. And for them to be healthy for others, they need to be healthy for themselves too.
Okay, well, this has been a great discussion. Thanks so much for sharing your tremendous expertise with us.
Oh, well, thank you guys again. I am so honored to be here. So excited you guys wanted to hear more about our perspective of fatty liver. I hope to work with all of you more. And feel free to contact me. I forgot to put my email at the end, but it's just Amanda Wieland at thestandard.edu.
Okay. Great. Thank you, Amanda.
Thank you guys.
Bye-bye.
Bye.